Let's now move on to the muscles of the anterior abdominal wall. The most anterior muscle to the rectus abdominis, a long vertical muscle extending from the ribs around T5 to the pubic symphysis. It is separated by several horizontal fibrous bands clearly visible on CT and ultrasound, and should not be mistaken for muscle injuries or post-trauma sequelae. These two rectus abdominis muscles, forming the most anterior and medial part of the abdominal wall, are separated by the linea alba. It is important to note that the linea alba may be relatively wide above the umbilicus, whereas the two rectus muscles are closely opposed below it. Another important point is that asymmetry in abdominal muscles is possible, particularly in athletes practicing asymmetrical sports like tennis, where only one muscle may be significantly hypertrophied compared to the collateral side. A small but relevant muscle to recognize is the pyramidalis, a triangular muscle with a broad base at the pubic symphysis, located over the rectus abdominis and visible for tensing the linea alba. It should not be mistaken for the rectus muscle lesion. Now let's address the muscles of the anterolateral abdominal wall. There are three layered muscles. The deepest, the transversus abdominis, plays an essential role in stabilizing the abdomen. It originates superiorly from the costial cartilage of T7 to T11, posteriorly from the thoracoumbular fascia, extensively from the lateral anterior iliac crest, and anteriorly, its fibers merge with the linea alba. More superficial is the internal oblique, a muscle involved in trunk rotation. It originates from ribs T10 to T12, also laterally from the thoracoumbular fascia and inferiorly from the iliac crest. These two muscles have a common anterior and lower insertion via a wide fascia. Even more superficial is the external oblique muscle, which originates from the ribs between T5 and T12. It lies close to the serratus anterior with shared fibrous attachments. It also attaches broadly to the thoracoumbular fascia and the iliac crest, and its aponeurosis contributes to the lower front part of the abdominal wall, along with the internal oblique and the deeper transversus muscles. An important nerve to know is the anterior cutaneous branch of the iliohypogastric nerve. This nerve, arising from L1, gives off two branches, a posterior one that innervates the supraposterior gluteal region, and an anterior one, clearly visible on ultrasound, that runs over the transversus muscles, follows the iliac crest and the inguinal ligament, and provides innervation to the lower anterior abdominal wall. This nerve can sometimes be involved in pubalgia, groin pain. Now let's examine the muscles of the anterior abdominal wall on ultrasound. We begin with the promedian sagittal view of the upper abdomen. Here we can see the insertion of the rectus abdominis blending with the inner fibers of the pectoralis major. Moving the probe downward, we follow the long muscle body with its fibrous bands separating the different segments. Another fibrous band extends down to the pubis. In an axial transverse view just above the umbilicus, the linea alba separates the two rectus abdominis muscles and appears relatively wide. However, below the umbilicus, the two rectus muscles are very close together, and the linea alba becomes virtually invisible. Laterally, we see the lateral border of the right rectus abdominis. And a fibrous line separating the rectus from the anterolateral abdominal muscles. This is the linea semilunaris, or the Spiegel's line. Even further laterally, we can identify the three layered muscles from deep to superficial. The three transversus abdominis, the internal oblique, and the external oblique. Slightly lower, we see the conjoint tendon, formed by the transversus and internal oblique, blending with the aneurotic fibers of the rectus abdominis. More laterally, above the iliac crest, we observe the laying of these three muscles. Between the transversus and the internal oblique lies the anterior neurovascular bundle of the iliohypogastric nerve, which we can track as it passes about 1 or 2 centimeters medial to the anterior superior iliac spine, toward the abdominal wall. It gives off sensory branches that may mimic groin pain. Tracking upward, we can follow this small neurovascular bundle running between the transversus and internal oblique. In sagittal view, starting from the lower iliac crest, we see the layering of the 3 lateral abdominal wall muscles above the iliacus muscle. As we move upward towards the rib, the external oblique crosses over the rib cage, with fibers intimately related to those of the serratus anterior. This is how I perform an ultrasound examination of the anterior trunk wall. At the thoracic level, we've reviewed the ribs and the costal cartilages, which are important in ultrasound because cartilage is only visible with this modality. Let's not forget the small intercostal muscles, which can sometimes cause pain mimicking rib fractures. Finally, the 3 major muscles of the thoracic wall, especially the pectoralis major, which is most frequently injured. At the abdominal level, it is important to be familiar with all 4 muscles, as muscle tears frequently occur within the muscle belly, causing small hematomas and pain in athletes. Grab your probes.